Let's talk patellofemoral pain and patellofemoral dysfunction. So, when I refer to the patellofemoral joint, I'm referring to the patella gliding on the femur. So, the femur has two condyles, round edges or ends on this bone, and we refer to them as a lateral and medial femoral condyle. In between, you have this concave surface called the trochlear groove, and the patella has a little bit of a ridge here, convex surface that is designed to glide in this groove. And whenever someone gets anterior knee pain, we refer to that as patellofemoral pain or patellofemoral dysfunction. We used to call it patellofemoral pain syndrome, but it wasn't the best way to describe because it wasn't necessarily like a whole bunch of symptoms related to one thing. It's actually multifactorial, and there's lots of different reasons that can cause anterior knee pain. So we just refer to it as PFP, patellofemoral pain in general. And so there's lots of reasons why this might happen, and no one really knows definitively. But when we are clinicians and we're looking at this, we need to find out why this patella is not grooving gliding correctly in this groove. So naturally, we have a lot of tight lateral muscles. So we have this retinaculum on the lateral side that's like just a tissue that's connected to the IT band on the outside and the vastus lateralis, which is the lateral quad muscle. And it naturally can pull a little bit, but we used to think that it was pulling on it, and surgeons were always going in and releasing that retinaculum, and they actually weren't seeing any difference. The outcomes were extremely poor with that. And so it really came to light that this is more of a dynamic issue. It's not necessarily that the muscle is pulling on it to the outside. It's just that functionally, when we dynamically land, we need to be able to have the right muscle balance and the right neuromuscular control. So the way all those receptors in our muscles, tendons, and ligaments communicate back to our brain, which, as you remember, they can have deficits and dysfunction after injury. So if you've had a lower extremity injury in the ankle, in the knee, and anywhere in the leg, you can have dysfunction communicating back that could be affecting this joint as well. So it's really hard to know. It's something that a lot of money is being put into figure out, but that's one thing that we think of. So it's usually there's some kind of neuromuscular dysfunction, or it's some kind of muscular imbalance or functional imbalance. That could be like muscle tightness, it could be muscle weakness. So we were for years focusing on the knee. So the Q angle is when you take from the ASIS, this bump on the front of your hip here, the anterior superior iliac spine, and you measure the angle from there to the middle of your patella down to the tibial tubercle. Women are going to have a bigger Q angle because we inherently have bigger hips for childbearing purposes. And so we basically have this bigger Q angle, and we have an underdeveloped VMO, which is that tiny muscle that kind of bulges out in the inside of your quad. If you look at women versus men, men will typically have a more developed VMO. So for years, we thought it was because of that. So all these lateral muscles are pulling this to the outside. And we've since proven that that's not true, and that actually you can try to develop it all day, but due to hormonal issues and Q angle things, women aren't going to really develop that. But also, if you do, it didn't really change the pull of the quad, because it was not so much about how it just functions like this. It was when we're landing and we're cutting and we're moving dynamically. So we had to look up at the hip. And so we are finding that there are some things to support that the external rotators, the glute max, glute min, glute med, those muscles, but primarily we're seeing the glute medius being an underdeveloped, underfunctioning muscle that really helps keep our knee from doing that valgus collapse when we are bending down and landing. So for example, you can take a patient and have them do a single leg step down. And so you want their knee to stay in line with their feet. Someone that has a weak glute med on the outside, you're going to see their hips shift like this, or you're going to see this knee valgus, that the knee is significantly going medial to the knee, and that means the hip is weak, and that's putting a lot of pressure on this medial knee and causing the patella to track outside of the groove. So we do think that's a big part of it, but it's also more than that. It's just intervening on the overall function of landing and cutting and moving, and then figuring out why we're not able to do that. So there's a lot, it's a multifactorial kind of approach. It's a really complicated injury, which is why I chose it. Because if you remember foot and ankle, I chose a straightforward one and then a very complicated turf toe. Same thing for knee. So what you need to take away from, in general, is just know as a clinician, we can't just look at where the injury is occurring. We have to look overall at someone's function and what they're reporting to us, and then look for the whole body and look at what else could be impacting that. For this injury specifically, what you need to remember is the patellofemoral pain is also known as anterior knee pain, and where it's happening, where the trochlear groove is, and then what is that thought on the Q angle, being an old school kind of thought. So read through the module and rewatch this video, and then also the new thought coming from the external rotators, but also like a more dynamic kind of thought of the landing mechanics and the dynamic movements of our hip, knee, and ankle working together. If you have any questions on this, please reach out.